Okay, welcome everyone. Hope you all had a great lunch. We are going to try to put on a very energetic panel for you, given that we all just ate. Try to make this entertaining. Really excited for our conversation today. The panel today is called Are We Thinking About Access in the Wrong Ways? Kind of intentionally a provocative title. I've asked our speakers today to try to lean into being a little bit provocative so we can have an interesting conversation. I'll introduce myself briefly. My name is Alex Katz. I'm the founder and CEO of Two Chairs. Two Chairs is a high-performing therapy provider organization. We W-2 employ all of our therapists, big emphasis on measurement-based care and exceptional quality. And we've got, I think, a really great group of folks with diverse perspectives to weigh in on the topic this afternoon. So I'm going to ask each of you to introduce yourself, and then we'll jump in. Verna, do you want to start?
Sure. Good afternoon. Glad to be here. My name is Verna Little, and I'm the co-founder for Zero Overdose and also the co-founder for Concert Health.
Hi, everyone. I'm Jenna Tregarthen, co-founder and CEO of Bright, which develops apps for engaging patients in the behavioral activation, all the work, the paper-based things that are now digital, the work that happens in between appointments across multiple diagnoses, and very excited to be here.
Hi, good afternoon, everybody. My name is Inderpreet Dhillon. I'm a practicing adult outpatient psychiatrist. Been doing that for about 17 years. 14 of those were with Kaiser Permanente in Northern California. For the past 3 weeks, I've transitioned to a new job with growth therapy. Do have a disclaimer and an observation. The disclaimer, that picture is about 15 years old. Most of those here were lost to access, and I'm more than willing to tell you those stories. And the observation is if you get a group room of people right after lunch to hear an access talk, this is going to be a good talk. So I'm excited to be here.
Hi, I'm Jennifer Christian Herman. I am a licensed clinical psychologist. I'm also the vice president of clinical strategy and behavioral health at Blue Shield of California. Blue Shield has about 5 million members across commercial and government lines of business. I also am a policy fellow with an organization called Inseparable, and am on the board of the Policy Center for Maternal Mental Health. So bring all of those lenses when I think about this issue.
Great. Thank you, everyone. I think, as you can see, we've got a great panel of folks with perspectives from health plans, provider organizations, and technology companies. So really excited about this conversation. I'm going to take a minute to frame up the conversation we're going to have today, and then we'll start getting the panel involved. Obviously, we're here to talk about access, which has been the key theme in the behavioral health industry over the last 5+ years. Between social change, COVID-19, there's been a tremendous demand for increased access to behavioral health services. That has come from consumers, it's come from employers, it's come from regulators. And over the last 5 years, we've been very focused on access to a first appointment, the size of the provider network that plans and other entities are able to provide. We've been focused on return access timing, the time between a first session and a second session. These are the metrics that I think so many of us in this room have been so focused on over the last 5 years. And the question that we ultimately want to discuss today is, are those the right ways to frame access? What are we missing in some of those metrics that we've been focused on together? So I'm going to pose that question to this group. Simply put, are we thinking about access in the behavioral health industry in the right ways today? Does someone want to take a first crack?
I'm going to take a crack, and I'm going to say no. How's that for being negative right off the... and I think just to start and kick us off, I think there's a couple of things. I think one is that we've really set ourselves up in some of the traditional ways that we've gotten paid, and sort of this assessment process, which isn't about patients or people at all. It's about us and our ability to build that code or to think that we need to sort of follow that process. And I think we need to completely think how people come into care and how we engage them into care and what that looks like, and even where we engage them. And I think moving away from that more traditional assessment approach, like even if you look in the DSM, it's an ongoing process. It's not a piece in time. And I think, just to finish the thought, when we look at our data in concert, one of the things we saw, over 96,000 patients, what it was the number of touches, not the amount of time, that was tied to outcomes and engagement. And I think we need to think about access and sort of follow that model. Right away, quick touches.
I can second on that no and double down on it. I think most of our access definitions have come from federal and state laws, regulations, policies, and the states and the local governments, when they come up with the policies, they're thinking about the mental health programs they're running. Now, what this leads to is a lot of disparity in terms of how we define access, how we pay for access, how we are measured for access. If access has to be measured as a journey rather than as a starting point of connection to care or a follow-up appointment. And part of that journey is not just getting the patient with the right provider from the get-go, but also ensuring that we are measuring how they are progressing through. Are they connected with the provider? Cultural, linguistic, angle, if that's the right fit. What are the outcomes with that provider? So beyond quantitative measures, we also need to have qualitative measures of access. What is the patient's lived experience through that? And I think bringing the patient's voice into any new definition or measure of access is going to be very critical.
All right, well, I'll triple down on the no. I think everyone, raise your hand if you think yes. And I think a couple of things in that. I mean, I do think we put so much more of the burden on the individual to find the care they need and to understand the care they need, much more so than if, you're going for cancer treatment, et cetera. You're not in a position of saying, hey, what kind of specialist do I need? Do I think I need this licensure or that licensure? So I think that just navigation, not only to finding the right level of care, but the right care that's really going to match your need. And then I think to really emphasize what you said, Ender, it's also the way we measure access doesn't all measure, is it access to quality care, and just the whole focus on needing to have more outcome-focused, evidence-based treatment.
I'm going to be slightly contrarian and say yes and no. I think, well, obviously, I think we're all driven by carrots and sticks. And I think, the parity legislation is really intended to be like a guardrail against the worst patient outcome. It was never intended to be our, guiding star of success. But I think I'm so energized being here today, and by what I've seen over the last, several years of this, of transformative care, where we're really trying to redefine what successful access means for individuals. And as you said, Indra, it's dynamic. It's not about, a binary, did we get them an appointment within 10 days? How long was it to their next appointment? Check in a box. I think, increasingly in a competitive landscape, to stand out, organizations are increasingly showcasing robust outcomes. And I feel like there's been a movement away from homogenized patients, toward deeply specialized, passionate, obsessive organizations that are trying to solve access needs unique to that population. And I think that's where we're really making ground. And thinking about in the privacy of this room, I shared with Alex earlier that my 5-year-old just received a level 1 autism diagnosis, and I'm so excited to hear about neurodivergence, being discussed today. But I think often if you're working in industry, you forget about the extreme pain and the deeply personal, difficult journey that any of our consumers went through to get to the point of that appointment. And that is a moment that you may not get again. That first appointment is the starting point. What then happens, from there is in our hands. And, our patients are evaluating messages that we're sending them from the beginning of their touch points. They're asking, can I trust you? Do you understand me and my culture, my background, where I came from to be here today? And then am I getting the relief of being supported and being held and being safe? And am I being navigated now through steps that I can feel successful in engaging in to start to notice change in my life? And you're going to have incredibly grateful patients and incredibly motivated care teams if you can chart that course. But what it looks like for different patient populations and how we define it is going to be completely different.
Yeah, I love that addition, and I appreciate you opening up about your personal experience. We've got a panel today of 4 clinicians, and I think probably all 4 of them have personal experience of how hard it is to navigate the behavioral health system, and these are the absolute experts, right? These are people that are at the very top of their field, and it's still so damn hard. I love that you centered the first appointment. To me, that is arguably the most important appointment in someone's mental health care journey. And a few stats to add to the conversation. I think everyone's heard this stat that the modal number of therapy visits today is 1. On top of that, we have found industry data that shows only 36% of patients get to a 4th session of therapy once they begin care. That's not successful access, right? Just looking at that first appointment is insufficient. And I'd love to get some comments from the panel about why do we think that's so common? We're doing such a better job as an industry of getting patients in need to a first encounter, but we really haven't gotten any better at getting them to a 4th encounter or to the outcome they deserve. Why do we think that is?
I think part of it is I have the opportunity to work with a lot of states, and a lot of the states have such antiquated guidelines for their mental health services. It is such a barrier to care. It is such a barrier to access. And not only access in the door, but what I'm going to call, because of these antiquated guidelines, the kind of scheduling and the kind of things that have to be put in place actually create scheduling nightmares in terms of blocking schedules and in terms of having to bring people back in certain amounts of times or certain amounts. And I think we need to blow all of that up and actually say, what do we know about a best practice, and really get state systems to move these antiquated guidelines and actually create real access for people.
Stickiness to care is the holy grail for outcomes. So the question is, why are patients not sticking to care? And I feel there are a lot of different reasons. Anecdotally, I've seen that in my practice, and as a leader in the mental health space, even in Northern California, this was one thing which we would talk about all the time, trying different things to increase that connectivity. A lot of times our patients talk with their feet. It's a one and done session, right? They are in a crisis or a perceived crisis or actual crisis, and they get what they need at that moment, but that doesn't mean they're being treated to remission or response. But that's what the patients feel at that time. So I think it becomes very critical to help connect the patient to the right provider from the get-go. Mental health systems are very complicated, right? Navigating a mental health system is difficult for anybody. I mean, imagine a patient who's depressed. It's going to be 10 times more difficult for them to do that. Lack of follow-up appointments. Now, you can create a system where you are getting your patients in within a day or 2 days or a week, but the follow-up appointment is going to be 2, 3, 4 weeks out. Good luck. Those patients are not going to come. There is also that stigma. I mean, I used to practice in Stockton, California, and there were 50 steps from the front door to the reception desk. And I would say, and this is pre-COVID days when actually people used to come into clinics, is these are the most difficult 50 steps somebody takes to come into the clinic. And they're difficult every single time for some of these patients. So I think stigma plays a huge role. I think what we need to do is we need to look at all these different variables which are impacting stickiness, and we need to come up with a cohesive strategy is how do we educate, empower our patients to stay connected, and from a systems perspective, how do we create systems that we're helping patients connect with the right provider, right time, and help them through their journey.
Yeah, excuse me, I think that matching with care is really important, right? If you take those 50 steps, you make that phone call, you do whatever that's difficult, and you meet with a clinician and it's not the right fit, and it often because you're sort of, it's like mystery dialing, like that person's name looks fine, or that's the only person with open appointments, and so you get there and it may not be a personal match, it may not be a match for the kind of care they're providing and you need, and so I think that's also a factor. And then there are just practical factors that are really significant. Treatment's expensive, and when you look at sort of copay for behavioral health, like okay, with parity, it may be equivalent to other specialists, but you're not usually seeing your other specialist every single week. And so for some people that, and people that are coming in person, just the practical aspect of getting your child out of school or getting yourself out of work to go, that really, can be the deciding factor for a lot of individuals around care.
I'm going to go back to 101 psychology. I'm not sure how many of you studied operant conditioning and intermittent random reinforcement. I get back to the fact that we're all just animals at the end of the day, that patients, when we're designing for engagement and stickiness, I think our digital product perspective can really come in handy. And we've seen, actually looked at the data yesterday, there's been 100 million homework activities completed on our platform by over 2 million patients across eating disorders, substance use, mental health. We just published a study with Kaiser that showed that patients within eating disorder treatment attend on average 9 more sessions over a 6-month period if they use our app versus not using the app. And we have a deep focus on science and looking at the data to understand what drives engagement. And no matter which way we cut it, the relationship with the therapist and leveraging those kind of operant conditioning models drives engagement. And what I mean by that is if a client is connected, even if they're just linked with their therapist, that they know their therapist can see them, they feel seen, there's someone on the other side that cares, that is a unique, private, secure, confidential place for me to process, disclose, become vulnerable, where I'm going to be held, and an app can actually create a compassionate, or a digital experience can be compassionate and really hold a client and give them skills in the moment. That is the difference. And if that person gives them feedback, or even if it's just a "I see you" comment, that we see a big step function in engagement. And I'm so thrilled to see, the codes that are being released for digital mental health, which is going to create the carrot to reinforce more of these digital tools in care. And it feels uncomfortable. It feels really uncomfortable for therapists, especially because you're decentralizing yourself. An app's going to help to solve your problems, not just me now. But if we are going to get real about scaling up the work and scaling up our caseloads and allowing therapists to prioritize and give personalized care, I think that asynchronous tool is going to play a really crucial part.
Great. One quick PSA, we've got QR codes up here. If you've got questions, scan that QR code, submit questions at the end. We'll have Q&A, and I'll pull them up on the iPad. So please submit those questions. Great conversation so far. I think we've established, okay, we're not measuring access in the right ways in the behavioral health industry. There are a lot of other things we need to care about. Are people sticking with care? Are they forming the right therapeutic alliance? Do they have the right digital engagement tools, and so on? I'd love to start to dig into that more now. There's so much more work to be done. I'm curious from each of your perspectives, what's maybe the 1 or 2 most important things we need to do next as an industry to not only provide access to something, but access to the right care?
I'll jump in first. So I think really build that whole ecosystem of care and broaden our definition that care is not just your weekly visit in person or telephonic with a licensed clinician. So I think that means collaborative care or integrated behavioral health, integrating behavioral health into primary care, integrating behavioral health into schools, workplace mental health, sort of the whole ecosystem, so we meet people where they are. It breaks down stigma, and it also really increases access. I think it's also use of technology, as you were saying, and I'm sure you guys will elaborate on that more. And it's broadening our definition of who provides care. For some cases, some individuals, some situations, you absolutely need a licensed clinician, and you need really high levels of care, but you also, peer support specialists, community health workers, there's so many other types of individuals that can help, and that also helps to break down stigma.
I think we need to look at from a pull and a push perspective and I agree with you, Jennifer. I mean, if we can take care to the patient, be it in a primary care setting or a school setting, and engage them there and keep them engaged, I think that is going to play a huge dividend. I think the other thing which we need to remain very focused is the therapeutic alliance through the course of treatment. Because radically, we need to look at access beyond numbers of initial access, follow-up access, and as a journey, and what in the journey makes the most sense to be measured. And one of the things beyond our PHQ-9s and GAD-7s, which you take a very big hammer to very small nails, right? Therapeutic alliance can tell you a story. And if you measure therapeutic alliance the right way, right, it is telling you something, it's telling the clinician something And having that focus is going to be very critical to maintain stickiness.
There are so many things. We're trying to organize the jumbled thoughts in my head. So, I mean, some bold things. I really would love to see heavy government subsidy or even paying for credentialing and education for therapists. If we really have a gap in skilled workers, I think that would be kind of the bucket wish list to do. There is some low-hanging fruit of, looking at underserved communities, marginalized communities. How are we showing up and representing those groups? What message are we sending that says you are welcome here? And so if there are patients with larger bodies, how does your waiting room look for those people? If there are, Black members of the community, do you have therapists that, they're going to see themselves in? And we know so much from the research now. Your Spanish community, do you have translated materials, product, services? I think having a focus on this, it's really hard. Like, even we're translating our product to Spanish, and it's not a great business decision. It's never the top priority for like an ROI driver necessarily, but the result is you're communicating a message to the whole community, which drives access to the groups that are marginalized, and we're not including the most. They would be some of the starting points. Social determinants of health. I mean, we have to mention it. I don't know if you've read Healing by Tom Insel. It's amazing, but like he talks about the 3 Ps. People, place, purpose. I have a family member who is in. So I'm sharing all the personal stories here today. I have a family member who was getting the best eating disorder service, the evidence-based practices, the CBT, outpatient, not working, treatment resistant. She changed her place. Her apartment was not a safe place for her to be, and she changed where she was living. She changed the people in her life, and she got focused on floristry. And guess what? She had a step function in her ability to recover and really engage with and see progress with that treatment. And so until we start seeing people in terms of their whole context, we're going to be hitting up against a wall. And I know these are hard things to tackle. I think having case management, I think the opioid world is doing phenomenal work. Shout out to Nick Stavros in the room and Community Medical Services, who have an undying, unrelenting focus on mission and access, and will do anything to break through whatever barriers are showing up to patients to keep them engaged in treatment. But they had a patient who disclosed in the app, hey, I'm sorry, I'm not going to be coming anymore because my husband just got in work and I don't have childcare. That's it. I can't participate in medication-assisted treatment. See you later. The fact that they actually communicated that means that the case manager was able to say, oh, wait up. Did you know that there's this free childcare that I can connect you with? Okay, let's get you back in. But they wouldn't have said that if they didn't have therapeutic alliance. If we're not talking to our patients, we're not learning about their individual needs. End rant.
I'm just going to go back to something that was mentioned around education, because I feel like if you're really going to take on some of the access, when you think about how we're training our behavioral health providers and some of what we just talked about here, how do I practice and optimize digital tools in my practice? I didn't learn that in school, and I can bet that no one currently getting trained is actually learning how to do that in practice, unless maybe they have a really good field placement, where they're doing that. And I think we really need to think about, what do we want clinicians to learn, right, around creating access, and then how do we get that into curriculum? And even when I think about, I had a discussion recently with the school, which was a little animated, but one of the things that they said is, we're no longer going to do virtual field placements. And I said, well, how does that really prepare your students when they are going to be doing telephonic care, they're going to be doing telehealth, they're going to be that is an incredible skill that they need to learn to be successful in the workforce today. And I feel like there is this huge push and pull, and it would be really helpful to bring the schools into some of these discussions, because I think they're totally missing the ball.
And all great comments. we've got on the stage the right set of perspectives. We've got the health plan view, we've got the provider view, we've got the technology platform view. We've got 4 great leaders that I think all agree we've got to get way better at access. Let's do some problem solving on the stage. I'm curious, from each of you, what are you looking for from your partners to really level up on how we're thinking about access to the right quality of care? So in other words, Jennifer, from the health plan perspective, you want to solve this problem. What do you need from provider partners? Or Jenna, what do you need from your provider partners that you're working, from a technology standpoint on?
Well, I'll start, but not a complete
Yeah.
answer. But I would say, we've really been pivoting or maybe adding on to our strategy, which has, as a health plan for a long time been, how do we build our network? How do we make ourselves the health plan of choice for providers? Well, I'm one of those providers. I don't really know anyone who actually takes insurance. And so that's a real challenge. And we need to do that. But again, that's not saying anything about the quality of care that individuals are getting. And so that's where we look to health plan partners, often technology-based, where they have a network, and that network is using an EHR. We're not, we're talking about access, but we really should be talking about outcomes and improvement. We want people to get better. And so we as a health plan often don't, if we don't have that kind of data coming back, then we don't. But I'd say our customers and others focus on how many sessions on average does someone get. So I think that's where we look to partners and have great partners who are able to do that, and then we're able to have value-based payment, really focus on some of those kinds of things. So, and I would say also some of our partners that are in some are broad-based, but some are more niche space in terms of, and maybe niche, that sounds kind of pejorative, I don't mean it in that way, but like youth specialty partners and different ethnic groups, different populations in terms of clinical diagnosis. So I think that's for us, just our overall network strategy has been pivoting a bit as well to think about who are the best in class at providing certain kinds of care, and how do we partner in a way that's tech-enabled that can actually help us to have visibility into what is happening and where we're getting high-quality care.
I'm going to jump in and maybe just think about some re-engineering for our practices, because oftentimes when you look at schedules, the schedules are full, but then if you look back, a lot of those slots were empty, right? People didn't come in, someone mentioned, well, I schedule out 6 weeks. Well, that's going to be an empty slot, right? So the access is there, essentially. The capacity is there. And a lot of times it's really around this scheduling and really helping practices to sit down and say, okay, we're not just going to measure productivity. We're actually going to look at capacity. How do we create access? How do we move to same-day, next-day scheduling? Like, this is really on the ground, in the weeds kind of support that many organizations providing behavioral health services really need. And I think somehow figuring out how to give that support in some ways is going to help to create access, particularly in some underserved and rural communities where it's just stuck.
Thinking about post-lunch, how brutally honest I want to be. I decided to go with utter brutal honesty. I have an ask of the policymakers. I think they impact how we do business. I have an ask around addressing the social determinants of health. What are the policies around that? What are the policies around the federal and the state governments reimbursing the right levels of care, be it integrating behavioral health into primary care settings? What are we doing about mental health in schools? I think the federal level, the state level, the local level, the policymakers are impacting behavioral health every single day. And I started by them defining access. But it's beyond a definition of access. It's the influence they created on the system. And the reality as of today is half the patients in the United States who need care do not get care. And the ones who get care, 50 to 60% don't come back for the second appointment. That's a reality. And I'm just a room full of very smart people, and I think this conference is and we will figure out some solutions, but we cannot figure out those solutions in a silo by ourselves. Payers, providers, tech companies, we have to have the right support from a policy perspective.
I completely agree with that. And I think we're a powerful industry. Like, the people at this conference today are powerful. And so being organized and being active and involved in policy decisions is going to be one of our most consequential influences. I also think, in terms of, you were asking about partners and you know, what we look for and what you can do, I guess what I'd ask of you for your organizations is, don't turn your back on the hard bucket patients. The fight to engage underserved communities is effortful. It's not always highly profitable, but it is so critical. And once you turn your back and you decide it's in the too hard basket, you've just closed the door. And I think so. Thinking about how you're including, your low income and minority group patients is really important. I feel like this is a conversation that's been going on for a long time, but portability, when I think about we can make magic happen if we can interact with a medical record system. The P in HIPAA for portability, I think the tide is finally turning on medical record systems, where the landscape is getting so competitive that if you don't have APIs and you don't play nice with other systems, you're out. And it is high time that was happening, because, with integration, we can send the right battery of questionnaires at the right time, like at admission, at mid-treatment, at discharge, at follow-up, without having a manual step process to do that. We can document in the medical record time spent in digital tools and then get reimbursement for it for the provider. The whole world of data flow and giving and opening up the data to providers to be able to innovate and be best in class, show that they are best in class, show their providers the results that they're getting, because this can be very thankless work for providers. Show them the results that they're getting for their patients is really motivating for them. But all of that is harder unless our systems talk. So I know it's kind of not a fun topic, but in terms of our partners where we can really innovate, that's really important.
Yeah, maybe not fun, but certainly important. I want to draw out a theme I heard from several of you, which was, I think, ultimately about how do we align incentives. We've got providers, we've got payers, we've got technology companies that care about very similar things. Sometimes these relationships can take on kind of a zero-sum characteristic, which doesn't serve anyone and certainly doesn't serve the patient. I'd love to hear from each of you on how can we get better at aligning incentives? And I think that probably means value-based care. I've been coming to this conference for a couple of years. I've been at a lot of healthcare conferences over the last several. It seems like we keep using that phrase and the progress has been slow. What can we do to accelerate in terms of aligning incentives?
I think one is really around measurement. And, I love that you kind of said, because you hear that value-based care, and in the field of behavioral health, that really has translated to nothing. And I think we need to think about, if the rubber was really going to hit the road, what would that look like? What would an episode of suicide care look like? Which fascinates me. What does that look like? We know what good care is now. We've learned a lot. What would that look like, and how would we get paid for it, and what outcomes would we look at? We've learned about depression care. We have tools to measure, how do we build that in, and how do we actually come back with some very specific models to try to do some meaningful pilots? Because I feel like unless we do that in some much broader, aggressive way, we're going to sort of, if you do what you've always done, you're going to get what you always got, and we haven't changed anything. And I think that's the next step, meaningfully.
Alex, I would say, let's define value for the patient. Let's define value for the provider. Let's define value for the tech company. Let's define value for the payer. Let's do a current state assessment of how does each one of them see value, right? Because at the end of the day, the patient wants to get better. The provider wants to have autonomy to treat that patient. And I don't think there is there might be some, but bulk of the providers want their patients to get better. right? So what's the value for them? What's the value? I mean, and I think our models of feedback-informed care, value-based contracts, which are two things which are linked but not similar, right, need to be aligned, but the voices of the patient and the providers need to be brought into the room as much as the voice of the payer is there.
I mean, I think just to emphasize what both of you have said, I mean, to truly do value-based care and value-based payment models, clinicians have to have a way of collecting that data and transmitting that data, and they have to have trust about transmitting that data. And I think that's a missing piece. I would say as a health plan, clinicians, like, why would I send this data to a health plan? So I think there's a lot of education and alignment that needs to happen all around to make those things happen.
That's a very critical point, Jennifer. I mean, creating trust for the patient and creating trust for the provider regarding any measure which we are collecting is going to be critical. Otherwise, the data we're going to get is not going to be accurate.
And can I say one thing too? This is kind of a little bit off the theme, but in terms of alignment, and I think when you said what do we each need for our partners, I would say as a health plan, also alignment with other health plans. I think if you asked me a few years ago, I'd be like, no, I want to differentiate. We want to be the best. But these are big problems to solve, and even like thinking about scaling integrated behavioral health, we've focused on that. We've had good success with that, but we've realized we've reached a point where unless we have multi-payer alignment in California, it's not going to be worth the while of medical groups to do this if they have to do it differently for each payer, different systems, different processes. This plan covers, this plan doesn't. So we've really been trying to do that and make that a partnership versus a competitive endeavor.
And I'm going to talk about continuity of care. Because for the patients, that other 50% who are coming back for an episode of care, right, we are treating conditions which go into remission and they do come back, right? So continuity of care becomes very important, and especially when you're treating chronic conditions which need appointments through the course of the year. Sometimes it takes longer than a year, and I'm talking about eating disorders. I mean, it's not easy. And gone are those days when people used to stay with one insurance company for the lifetime. Everybody's changing insurances every year, and so I think on the back end, any sort of collaboration from a continuity of care perspective is going to be very critical, especially for the patients who we have managed to engage with care and are on their journey of getting better.
It's a tricky question. I think there was a period where we saw provider partners, it was really a goodwill and quality investment in software, where it was like, this is the right thing for our staff, for our quality programs, for our clinicians, for our patients. And is there going to be ROI? Maybe not. And, when it comes down to crunch time, depending on your CFO, like, are they going to fund it? Are they not? I mean, you've probably all been on the other side of that at some point, or on the other side, one side of that fence at some point. I think the tide is turning. We have very clear evidence at this point that sticky patients are a good investment. That if a patient stays and meaningfully engages in their care, then from a really economic perspective, it's good for everyone, for the clinicians to see through their patients in their journey, and build the relationships, and for the organization. Unfortunately, we've had some pretty disturbing experiences with health plans. Our platform, quantifiably in multiple studies at this point, increases outpatient retention and engagement, and decreases emergency room admissions by 3.8-fold. This has been found in claims analysis, in clinical trials, and the amount saved from the reduced emergency room admissions does not offset the amount paid from keeping a patient engaged in care for longer at scale. And our contracts have been terminated for that reason. I think there's a long way to go with health plans. I mean, when we're measurably improving quality, measurably improving access, systemically collecting outcomes, parity needs to be enforced and come into play, that is a good outcome, even if it's a more expensive outcome for the health plan. So I'm really, obviously as a vendor, we don't have a lot of, like, parity doesn't apply to us, unfortunately. But I'm really excited about these digital mental health billing codes. It's the first time providers are going to get adequate reimbursement for clinician time spent engaging with patients in these ways that keep them in care. And I think the call to action to health plans is to come on board and honor those codes. It's also been really challenging to see the constraints on licensed professionals to access some reimbursement in areas such as opioid treatment. I cannot underscore the shortage of skilled providers. It's kind of at an acute crisis in that area, and because of a lot of the programs are taking on training themselves and taking on and investing in people, but a lot of the reimbursement doesn't apply because of the requirements on those providers. So there's some real challenges there, I think, in terms of economic incentives.
Well, thanks so much to all of you. Appreciate you bringing just a really diverse set of perspectives. Inspiring to me to see people from all across our behavioral health ecosystem so committed not just to access, but also to the right access and the outcomes that our patients deserve. We've got a few minutes left. I want to open it up for Q&A. Just raise your hand and we'll call on you, and excited to broaden the conversation. Please.
Yeah, I would love, I have been talking to employers and employer groups for years, trying to get one of them to really embrace collaborative care, to actually be able to sponsor, to, do some broad screening and to, provide collaborative care, and then to look at the impact that had. So I would love to figure out how to meaningfully engage employers in the conversations. And figure out some ways that we couldn't engage them to create access, because people are at work, right? I mean.
And I'll just add to that too. I think similarly to do partnership with employers, because I think employers understand fundamentally like how this impacts their bottom line, not just their total cost of healthcare, disability, workers' comp. And so I think taking that comprehensive view and partnering with them to understand that because I think then that helps to move away from just the how many sessions are people getting, but it's about people getting better, but it's also about all the other indirect effects.
Maybe time for one more. Yes.
Hey there, I'm Rachel Strife, Arizona Mad Moms. Welcome to Arizona. We have the fewest state hospital beds per capita of any state in the country. And as a result, our serious mental illness population is incarcerated 32 times more likely than they are to be hospitalized. I was hoping to hear more about access to treatment for serious mental illness from this panel. Anyone want to comment on that one?
I think part, and working some with that population, is I think there is no access by some of the individuals who are touching those folks for some of the online or digital resources. And there are some really good treatment services that are available online, and I don't think people even get connected to them. And I would love to figure out ways to bring some of those resources onto the ground, because in some places that's going to be the primary way that people may get access.
And I'll add to just the necessity of care, and also that care is not enough, and things like, community-based models of care, things like the Clubhouse model and other things that help to wrap around and not just address the social drivers of health, but also that connection, that purpose, that meaning. I think that's, treatment is a gap, but treatment alone is not enough, and you really have to really think about this holistically if you're going to help people not just to have symptom reduction, but actually be able to have productive lives.
Thank you so much for giving voice to those individuals. I mean, it's just devastating. And we could boil the ocean with this panel, and I'm sorry that we didn't address them because, and I think the legal system needs to be involved. It starts with the Department of Prosecutions, and it starts with, collaboration with law enforcement. I know there's good work being done in Arizona with partners like community medical services in opioid treatment and getting medication-assisted treatment for these populations, but my goodness, we have to turn the tide, and it is not okay.
I think there needs to be a lot more investment in community treatment and wraparound services. Those patients, we need to look at them, and these are patients in high need, both psychiatrically and medically. And if you think about it, what's the total cost of care for treating these patients? Because their diabetes, I mean, half the medications which give them give metabolic side effects, high blood pressure, diabetes, obesity, you name it, right? So we need to kind of have that holistic approach of treating them in the community, not just their mental health conditions, but the physical health conditions, have enough wraparound services for the social determinants of health, and work very closely with the legal system. Because right now, you're right, it's a coin toss for a 17-year-old with first break schizophrenic. And most likely, they're going to land up in the justice system, not the mental health system.
Well, thank you for those really thoughtful questions. Unfortunately, we're at time. I wish we could go around the room for a lot more, but I want to thank our panelists for a really fantastic session. And I'm just going to close us on a final note, which is if you came to this panel, you probably agree that there's something wrong with the way we define access in this industry today. As Jenna said, we've got powerful, influential people in this room. Let's do the work together to make access encompassing of quality and outcomes. That's what our patients deserve. Let's go do the work together. Thank you, everyone.